a mode which owns the rich and voluminous perspective that's coming into my senses, the images, the sensations, the intuitions, the convictions. All of that can be, as part of practitioner subjective. I can speak to that without making claims that demand the credulity of someone else who hasn't had that experience, right? If somebody says, "How was your day?" and you say, "Good, I had a good day," and the person says, "You didn't have a good day, it was raining outside." It's laughable, isn't it? Laughable that they would deny your direct experience of having had a good day. They don't have any claim on your direct experience. Likewise, no one has a claim on what I'm experiencing as a practitioner. That's me. That's my world, okay? But likewise, I can't expect someone to believe every image that flows through my brain just because I experienced it. There's too much filtration happening there. There's too much conditioning to my felt sense. And if I want to be a grounded, responsible healthcare provider, I need to be really careful with the link between this and what we call objective objective experience. And for our purpose here, objective is not the practitioner or the patient's perspective. It is what a third trained observer would be able to surmise just happened in the room. So, I've got my hand on a patient. I'm approaching it in a way that I was trained. I've got images in my head. I've got experiences in my hands. I've got a patient who's having their own experience. Patient subjective, practitioner subjective. What about the third observer? What about the person who's trained to observe changes in a body? Maybe they're a healthcare practitioner or a researcher, and they're standing in the room and they're observing with their eyes, or maybe they're observing with instruments. But they are a third person who does not have access to the direct experience of the patient or the practitioner. My definition for objective is what that third person would be able to agree just happened. And there's an advantage to that kind of construction. It means that we can speak very clearly about what objective is. Objective would be a change in the color of the skin, a change in the breath rate, change in the heart rate, change in the range of motion. Objective would be a change in some skin conductance, some autonomic signal, okay? But it also means that I need to learn to value, as Shay has been saying, I need to learn to value and work from the practitioner's experience. I need to be able to validate this without thinking it's something that it's not, okay? So often when we as practitioners are trying to learn how to be good practitioners, we want to legitimize this by pretending it's that. And it's not just us that's guilty of it, it's our teachers, it's our literature. Go into the osteopathic literature of the last 100 years. Read articles and you'll see articles that say, in fact, just go to any medical literature and you'll see articles that say the patient displayed hypertonicity in their anterior scalene. What do you mean they displayed hypertonicity? You mean you went feeling for their anterior scalene and it felt tight. That's what you mean. The patient displayed a subluxation of their 6th thoracic vertebra. What do you mean they displayed it? What do you mean they just have a subluxation? What you mean is you went feeling in the mid-thorax and you felt a segment that was had a different alignment and maybe was reactive, and you felt it. So put yourself back in the story. And that's a way to talk about direct experience.